This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco with the Neurology podcast, and today we're finishing up our Autoimmune Encephalitis update series. Our last episode was hosted by Owen Flanagan and Grace Gombolay, sharing with us some red flag symptoms to consider when working up a patient with autoimmune encephalitis and ways to expand the differential. Today, we're joined by Maarten Titulaer, an associate professor of neurology at Erasmus University Medical Center in Rotterdam, Netherlands, where we're discussing the importance of longitudinal care. I think over the past few years, we've really seen the pendulum swing in terms of increased awareness of these immune-mediated disorders within the hospital. And even on this series, we focus mainly on that setting, but these patients really need a long-term follow-up, and the outpatient setting can present some unique challenges. So I'm really excited to explore this topic with Maarten today. Hello and welcome.
It's nice to be here.
Maarten, maybe we could start with some common syndromes like NMDA or LGI1. How do you approach those patients as they leave the hospital?
Basically, we use quite general perspectives, although every patient will need a personalized approach. But if you compare NMDA and LGI1, the two most common symptoms, they already show real big difference in how I approach them.
Why don't we start with NMDA?
Well, NMDA, of course, many of these patients have been extremely ill, spend a long time in hospital, and then they often go to rehab or sometimes to psychiatry, rehabilitation, and afterwards they get home. And then there's several challenges. One is to consider, do we need additional immunotherapy? And the other item is, do we need another symptomatic treatment? And the third one is, do we need adaptations for patient or family care? I think those are the three essentials. The immunotherapy, generally, it's quite easy. NMDA tends to be a monophasic disease. And therefore, once you've done your immunotherapy, we basically don't treat them beyond with immunotherapy. I would say general miscommunication often heard is that patients are treated with rituximab for years because people assume it is something like NMOSD, but it's not. It's more like GBS. So it's a one-time disease. Most patients will only need treatment in the acute phase. I think this is a huge difference and an important point to raise. Of course, there are some patients who will develop a relapse. This is getting probably a little bit lower anyway, because people are more treated by aggressive immunotherapy than they used to be 10 years ago. But also, if you coach your patient and family well, they will recognize the relapse early on, and then you can still treat them. Otherwise, you're treating patients for several years without any proven additional efficacy compared to not treating them. We, of course, have shown that rituximab prevents new relapses, but in those patients, 94% of the patients received one round of 2 to 4 courses of rituximab in the acute phase, but no repeated infusions. So I think this is very important, and too many patients receive multiple bouts of rituximab, which I think is not necessary, or azathioprine or mycophenolate. The second thing is symptomatic treatment, and generally patients tend to have a lot of symptomatic treatments because at the ICU or during their acute phase they were severely psychotic or had refractory seizures, so they end up with multiple drugs, and most of them you won't need them in the end. Of course, this might take a while, and you shouldn't directly taper off everything. This should be done very carefully, monitored by us, by psychiatrists, by people caring for seizures. But in general, within a year, almost all patients can be tapered down from basically all medication. That's at least my experience.
And I like that contrast with MS or NMOSD. I think those are the weird diseases, right? Requiring lifelong treatment, whereas these diseases can be monophasic. Treating 1 to 2 years can be sufficient in order to control this disease and give them a good chance for rehabilitation with the right services. Is that right?
Yeah, and I don't even think in most patients 2 years is necessary. I basically don't retreat them, at least for the NMDA. I've seen some patients relapsing after 6 years or after 10 years, But if I would have started them on rituximab or azathioprine, I would have probably stopped them after 2 to 3 years. So I'm not sure that this relapse after 10 years would have been prevented by treating them for some short time. However, if you compare this to LGR1, I would say this is in a way, a different disease. In those patients, we see relapses in about 1/3 of the patients. And we used to treat them only by steroids in the acute phase and IVIG or plasma exchange, and then taper down the steroids in like 6 months or something. In those patients, we saw that still about 30% of them would relapse. And that's quite a high percentage. So in all my patients, I do discuss the use of azathioprine or mycophenolate to reduce this frequency. Of course, there have been no trials, but at least we see that our relapse risk has dropped to like 5 to 10%. Alternatively, rituximab in the acute phase or in the post-acute phase, just this one round of the rituximab probably has the same effects, at least for the initial years. And currently, we don't know whether you should repeat it and how frequently. This also probably depends on how your disease initially was. LGR1 is, in a way, also an easy disease because once you have seen the initial episode, the relapse is easy to predict because the relapse is exactly the same as the initial episode. So if it started with panic attacks and goosebumps, then the relapse will start with panic attacks and goosebumps. If it starts with FBDS, then your relapse will be facial brachial dystonic seizures as well. So you can really instruct your patient to recognize those, the family to recognize those. And if this is the case, then you can treat them within 2 days. However, patients would probably prefer not to have any relapses at all, or sometimes in some countries, if you get one seizure, even if it's the FBDS, you can't drive for 5 years. So that's, of course, then it's more important to avoid relapse at any cost. And in those patients, you probably providing them with chronic immunotherapy would be relevant. Of course, after 3 years, you still have the same question, like, okay, should I continue or should I stop? And this is really a personal case-by-case comparison. For example, we tend to do serum antibody levels if we consider stopping treatment, and also the voltage-gated potassium channel test. And we do it before and then 4 months after the cessation of the azathioprine, and then we see whether the antibodies come up or if we should be worried about relapses. Of course, this is all still a work in progress, but it seems to be working quite well. Some patients actually refuse chronic immunotherapy in LGR1 or Caspar-2. And in those patients, we tend to watch them closely. And especially the Caspar-2, they tend to relapse maybe a little bit more frequently, even like 50% or even more than 50% of cases. And those patients, when they have had a relapse and we treat them early and aggressively afterwards, they probably are more open to receive chronic immunotherapy. So in that way, you always need to be in consideration with your patient and have a shared decision making.
I think the exact approach isn't clear, but what is needed is that long-term comprehensive follow-up, right? Because these patients can relapse years after their index event. And so having that plan after they leave the hospital is really important. You've mentioned this a little bit on these relapses and some approaches, including antibody testing. Are there other things you do when you're considering or concerned about a relapse? And how do you differentiate that from other symptomatic pieces for this disease?
Generally, the new symptoms in patients that have had an encephalitis are a relapse until proven otherwise. So, for example, in LGR1, the seizure risk is low. So if they develop new seizures or the same seizures they had while they were seizure-free, then you should first consider it is a relapse until proven otherwise. So, of course, we check for infections because they can provide pseudo-relapses, just like you have in MS. We check antibody level, and we also tend to use antibody levels in remission so that we can compare. So, for example, the LGR1 commercial tests tend to remain weakly positive. So then it's helpful to have this basic value when they are in remission, so you can compare to a state of remission and not comparing it to the acute phase of the initial episode. And the same holds true for Caspar-2. Generally, patients remain antibody positive, but we use the VGKC to have a tighter And that seems to work quite well. Currently working on this item to show that it's actually working well as a predictor. For other antibodies like NMDA, it's a little bit more difficult. We know that serum antibodies are not very sensitive nor specific for relapses. And to have CSF in, while the patient is in remission, is often difficult. So for these patients, it might be difficult sometimes to see if it's relapse. Of course, if the patient is antibody negative or very weakly positive, it probably is not a relapse. However, if it is clearly positive but lower than it was in the acute phase, you're a little bit stuck in the middle because you don't know whether this was what was remaining from the initial episode or that this was an increase compared to the remission state. We checked whether NFL could be relevant, so NFL in serum, and NFL in serum can be of some value. However, it's a slow marker. So if you do it in the acute phase, it won't help you. But if you do it like 1 or 2 weeks later on, you might see that the NFL increases. And then, so in retrospect, it can help you to decide whether this is a relapse. So if we looked for patients where we had NFL levels in the acute phase, in the remission state, and in their relapse, we could see that the NFL increased, but only a little bit later than the symptoms started. So that's only partially helpful. And of course, we do MRI if you show limbic abnormalities, like normally can occur in encephalitis, but are not necessary. It will help you. If you have EEG background pattern slowing while it was normal during the remission phase, this can help you. But this is all indirect. And in the end, it's also a clinical decision.
But using those same tools you used at the index diagnosis to help differentiate a true relapse versus a pseudo-relapse, I think that's really helpful.
Yeah, the only problem is that the antibodies can remain positive even if you're recovered. So then the antibodies are a little bit less black and white than they are in the initial episode, especially for NMDA. This is a problem.
So we've talked about some antibody-mediated syndromes. I think, how about those antibody-negative cases, right? That can make up a sizable portion of a clinic, and it can be really challenging. Do you have any pearls on those cases?
I think that seronegative autoimmune encephalitis probably is a mixture of several diseases. And some might be antibody mediated, some might be T-cell mediated, some might be monophasic, some might be relapsing. So that's even more challenging disease group. I think that there are differences between like those one that follow the strict rules of probable seronegative autoimmune encephalitis according to the 2016 Krause criteria. That's still quite a small group. And in those, initially I tried to taper off everything and see what happens, because I don't know whether they will ever relapse. And all medication also has its side effects. So I tried to taper down, and only if they relapse, and I might actually do the analysis again to be sure that this is the good diagnosis. And only when they have a relapsing disease, then I might consider to put them on more chronic immunotherapy, and depending on all additional circumstantial evidence, considering azathioprine, mycophenolate, rituximab, sometimes cyclophosphamide. For the ones that do not meet the criteria for seronegative autoimmune encephalitis, so they have MRI abnormalities that are way beyond the temporal lobes, they have DWI restriction, they have contrast enhancement or changing things or atypical items, I would be a little bit more careful. And I tend to follow them very closely and still reconsider the diagnosis when they're relapsing. Is this really inflammatory? Am I not missing any opportunistic infection? Am I not missing a lymphoma? Is it not something I should reconsider? Because we know that patients that meet the initial criteria for possible autoimmune encephalitis, only a quarter of them actually had autoimmune encephalitis. And a lot of the patients had several types of mimics that just needed a lot more ancillary testing. So if they do not meet strict criteria, you should always be worried about a differential diagnosis. And therefore, I'm always a little bit reluctant to start them on chronic immunosuppression, because that will really destroy all diagnostic opportunities. or secondary, more aggressive immunotherapy. If it's a Whipple's disease and you put them on rituximab, that's not very good for their outcomes. So similar for some other low-grade infections, initial lymphomas might be responding well to steroids as well, but then in the end, you're missing the opportunity to treat them in the right way. So in those patients, always reconsidering, okay, should I not go back to square one, doing the diagnostics again? Am I still on the right track? And only if I'm really convinced, or sometimes even after biopsies, then continue to go to more aggressive immunotherapies or chronic therapies.
I like that idea of constantly rethinking about it. And I tell patients that too, right? That worry about those indolent infections or cancers or malignancies, right? Keep me up at night a little bit. And being open and honest with the patient that we'll continue to reassess, I think, is a reasonable way to approach these really challenging cases. Another question that comes up often is cancer screening in this population. So in the hospital, right, feels like everyone gets the CT, chest, abdomen, pelvis. How do you approach these cases, though, on the outpatient basis? What tests are you employing, and how do you think through it?
It really depends on the type of antibody. So patients with high-risk antibodies like HU or CV2 or AMPA receptor, those we tend to screen them every 6 months. Could be CT or it could be a PET scan. If it's, for example, a patient with NMDA, like a child of 5 years old with NMDA, we only do screening in the acute phase, but we don't do any repeated screening because the chance of a cancer is very, very low. Of course, if patients relapse, we do a re-screening. Also for LGR1, which has a very low risk for tumors, we screen in the acute phase, but afterwards we don't do repeated screening unless patients relapse. For Caspar-2, it's a little bit the same. Mostly when they relapse or if they are refractory, we might do repeated screening. So this depends on the combination of antibody, clinical phenotype, and also additional cancers that may have already been identified or other factors, like if they have herpes simplex virus before NMDA, that also has a very low risk of tumors. And generally, I use the PNS care score. So that's in the updated 2020 Krauss paper on PNS criteria to assess my risk. And the screening frequency depends on the likelihood of a tumor. For seronegative autoimmune encephalitis, generally we screen in the acute phase and we don't do standard repeated screening because we don't know whether this is anyway paraneoplastic, what are normal figures. Of course, if they're refractory or multiple times relapsing, those might be different cases and these might be red flags to repeat the screening.
I think we talk about this all the time about not over-relying on an antibody result. But I think the cancer screening is one where we can really lean on some of the evidence where guides that approach which cancer we're looking for, which modality we should use. So that's really helpful. And then I appreciate that comment about those seronegative cases because those can be hard. I know we also talk about age-appropriate cancer screening measures that they should be keeping up with and nudging them towards their primary care doc to help get those done as well.
Yes, especially for the children, putting them on repeated CT scans probably is not very useful and potentially risky. So you completely agreed.
I know you mentioned this at the top, but what other services or consultants do you use for these patients? We talked about that importance of rehabilitation, but do you have any practical points on that end?
Well, I think it's important once you start the recovery to incorporate rehab very quickly. And initially, they will be reluctant because your patient is too severely affected and often they have very low attention span. So they say, no, it's not possible at this time. But once they start improving, you often can reach a lot of improvement in a very short time. And then showing this change to the rehab facility will also show them that there actually is a lot of potential in these patients. So that might help to increase their enthusiasm, because these patients are difficult for rehab because generally they have a combination of physical, cognitive problems and behavioral problems. And especially the behavioral problems might be difficult in a regular rehab setting to handle, while patients in the regular psychiatry ward only, the psychiatry rehab might not be challenged enough to improve physically well enough. And because they have lost a lot of their stamina, a lot of their physical potential due to the long admission. So in a way, I think it's very important to have both rehab and psychiatry involved in these patients, also making a plan how to taper down some of the medications, especially if you have a lot of anti-seizure medication and antipsychotics and sedatives, then these patients have some attention to all the tasks they should do. Additionally, I think neuropsychology is relevant to see how many domains are involved and what things should be taken care of during rehab. And of course, social services should be important as well. Many of these patients, especially in NMDA, are quite young, so they impact the whole family, the whole social system, and therefore it's also important that you take in this whole process, take the family and the social environment, because they have to get used to a patient that often has no recollection of their disease episode, so they have no clue why all these people around them are this worried. They have only like sketches of part of the disease, so they don't know why everybody is so concerned. And sometimes they have frontal disinhibition, or they might have apathy. And all these items might be difficult to cope with, not only by the patient, but also by the family members and the caregivers.
They have so many needs. I think you touched on a couple of them, right? This physical, emotional. I love that point about their social or financial needs that we have to think about and try to get them hooked up with the necessary services. So it's really helpful. And then that last point you made about caregivers, I think it can sometimes be overlooked, but they're crucial players in a patient's recovery. How do you help care for the caregiver?
Well, it's difficult because we as physicians are not very used to dealing with the family otherwise than informing them, probably showing them that we recognize it, showing that they're not the only ones that go through this, that sometimes you can help them meet other families that have suffered the same. And this can be patients with encephalitis, but can also be patients with other acquired head injuries, because a lot of the fears, a lot of the remaining symptoms can occur also in a lot of other diseases. They might have different angles, they might have a little bit of different weighing of the different items, but still, patients with a multi-trauma that has somewhat recovered but still have sequelae can quite resemble some of the symptoms that you would recognize in a patient after encephalitis. So they can learn from other patients with encephalitis, but also from other caregivers, from patients with other brain traumas. And recognition is important, helping a little bit in expectations about how quickly things will go, but also the idea that patients will improve, but it will not only go up all the time, so that they might have hiccups while doing the recovery. That is quite common, that there is a difference between a rehab setting and a setting at home where everybody expects so much more from you. The idea that they can't ruin their brain by doing too much, that they will just suffer for a few days to recover from their overachieving, maybe during like a simple party or anything that we would consider nothing special, might be still too much for those patients at sometimes, but that they can't hurt it, as long as they know that they might hit the wall, but that in the end their brain will not be impacted. That's important. And maybe even the other way around, what we saw in children that were smothered too much was that they actually had more problems in the end. So that it might even be important to try to trigger patients to pass their borders sometimes, to overcome their apathy, and therefore try to recover as good as possible. And you cannot completely take away all challenges in life.
You're definitely walking a fine line, right?
Yes, no, definitely.
But that importance of normalizing, I think, for both the patients and the caregivers. Well, Maarten, I want to wrap things up. I can't thank you enough for taking us through this whole spectrum. This is a huge topic to cover, from post kind of acute care for autoimmune encephalitis patients, but some really helpful practical pearls here. And so thank you for your time. And we can't wait for you to join us back on the podcast.
It was a pleasure. Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.